Okay, so I'm not going to spend a whole lot of time talking about the anatomy and physiology because we already have, during the first half of this block, but let's just go ahead and review things real quick. So the respiratory system is divided into the upper and lower airways. We know what it does, right, what it's responsible for. Essentially, it's responsible for what? Respiration. You have two types, internal and external respiration. Diffusion of gases, right? And then, of course, you have filtration, humidification, and heating of gases coming into the body. So when we look at the upper airway, what goes on the upper airway? Well, filtration of stuff, humidification, warmth. What's phonation and resonance? That's all talking, right? When somebody phonates, that's the ability to talk. That all occurs in the airway. With resonance of the voice occurring primarily in what are known as your sinuses. And you guys know your sinus cavities, right? You have pairs of them below and above the nose. And they provide kind of a resonance for sound as it kind of travels out of your mouth and resonates in through your skull. The sinus cavities are also covered in mucus and pseudostratified columnar epithelial tissue to kind of collect and filter things out as well. Mastication, which is chewing and then swallowing, and these are associated functions. They're not necessarily airway or respiratory system specific, but we know that components of the respiratory system are still involved in that, right? The epiglottis, for example. We need the epiglottis to work and able to successfully swallow food, otherwise we have problems. Okay, so when we look at the upper airway here, I have a little cross section of the upper airway, right? You've got the nair, you've got the mouth here, right? You've got these concha here in the nasopharynx, and they're large folds that increase the surface area, and they have hairs on them, and they help filter, heat, and humidify air as it goes through. Right, and then you've got your pharynx back here. You've got your nasopharynx right behind the nasal cavity. You've got the uvula. It's a little flap that helps guide the bolus of food down into the esophagus when you swallow. That's the role of the uvula. You've got your oral pharynx and your laryngeal pharynx as well, and the nasal, oral, laryngeal make up what's known as the pharynx or the pharyngeal cavity. You've got your tongue as well. It's attached the hyoid bone, and then you also have the epiglottis that attaches underneath the hyoid bone, and the epiglottis covers the trachea when we swallow. You guys okay with that so far? Nothing crazy there. The esophagus lies behind the trachea, or should. Okay, so looking at the anterior view of the neck, we have what's known as the larynx, right? And the larynx is the distal portion of the upper airway. And remember, we talked about the different cartilages. You've got your thyroid cartilage here. That's that large bump that moves around when you swallow. That's also known as the Adam's apple, right? And then right underneath that, there is that what we call the cricoid membrane or the cricothyroid membrane. Of course, you guys all got to simulate that in the lab yesterday when we did surgical and needle crikes. And then the first bump underneath that is the cricoid cartilage. And then you have the trachea and your tracheal rings. Here's the view of the glottis, and of course you guys know this or should know this because you just had a quiz over this, right? So you've got the tongue, you've got the vallecula, the epiglottis, you got your vestibular folds. Okay, these are known as the vocal cords. This is the glottis here. Of course, you've got your major cartilages, your cuneiform, your corniculate, your arytenoid cartilage, you got the arytenoid notch, and you've got your esophagus underneath that. Not new stuff there. Okay, looking at the lower airways, remember we talked about the conductive versus respiratory. Conductive is where gas exchange doesn't occur. Respiratory airways where we have gas exchange occurring, right? And we talked about how the airways bifurcate or divide out. And so you've got your trachea, your bronchi, your segmental bronchi, your lobar bronchi, your subsegmental, your bronchioles, your terminal bronchioles, your respiratory bronchioles, your alveolar ducts, and finally your alveolar sacs. And anywhere from 20 to 28 generations or different divisions until we get into the actual respiratory airways where gas diffusion occurs. So far, so good? You guys good with that so far? All right. So here you have your bronchiole, the terminal bronchiole, and then the terminal bronchiole ends in what's known as an alveolar duct, and multiple sacs are attached to that duct, and you have the individual alveoli themselves. The alveoli can actually communicate. They're actually little pores that connect different alveoli, so the pressures can kind of even and equal out, and those are known as pores of Kohn. Clearly that's a detail that you're not going to have to spend too much time learning. All right, we also talked about the mucociliary escalator, right? The mucociliary transport mechanism. We said that the conductive airways primarily are lined in what's known as pseudostratified columnar epithelial tissue, right? And you have these columnar cells that have cilia on them, and then embedded throughout there you have these goblet cells that secrete the mucus primarily, and they primarily secrete mucus in response to parasympathetic stimulation. So the parasympathetic nervous system is what activates the goblet cells and causes them to produce mucus, and that's why when you have a parasympathetic response, you get lots of secretions that can build up, in addition to the lowered heart rate and all the other things that we see with the parasympathetic nervous system. And that's also why giving drugs that block the parasympathetic nervous system, like the anticholinergics such as Atrovent or ipratropium, might be helpful in some patients because it can help with excess mucus secretion. You guys good with that so far? All right. And then the mucus layer rides on top, and then the cilia beat, they sweep very quickly, and then they sweep that mucus layer from the lower airways into the upper airways, and you either expectorate, i.e. cough the mucus up, or you swallow it. And then here's looking at the alveoli itself, right? We said we had the type 1 pneumocytes where the gas exchange occurs, right? It's one layer, right? It's what we call simple squamous. Squamous is flat, so it's simple. Simple is one layer. Squamous is flat. We call that simple squamous epithelial tissue where gas exchange occurs. And then you also have these type 2 pneumocytes that secrete surfactant, which helps decrease surface tension and helps maintain the alveoli and keep them from collapsing completely when we exhale, right? We talked about the law of Laplace already, and how when the diameter decreases, the amount of force or pressure it takes to reopen those alveoli is going to increase substantially, so we don't like alveoli to collapse. We know that if you have lots of atelectasis, that can increase the work of breathing because you have to kind of pop those open like kind of blowing a balloon up for the first time. And, of course, that can cause damage. The constant popping open and then collapsing can damage the alveoli as well. Oh, look at that. There's a pore of Kohn. All right. And then the macrophage, which are white blood cells. They are phagocytic white blood cells that are within the alveoli, and they're kind of like the final defense layer for stuff that can get into the lungs. Okay, so, all right. So let's look at the lung. Remember we talked about it being a negative pressure mechanism. So here they lie within the thoracic cavity, and the lungs themselves are in the pleural cavity, and then the mediastinum contains the heart and the great vessels. And both the mediastinum and the pleural cavity exist within the thoracic cavity. We talked about the pleura that lines the lungs, and you have, just like a lining in any other area of the body, you have a visceral and a parietal, and that's the case with the meninges in the brain. It's the case with the peritoneum in the abdominal cavity and pelvic cavity. You also have, that is also the case with the pericardium when you're talking about the mediastinal cavity. All of the body cavities have this lining. Same thing with the lungs. Okay. We know that the lungs are divided into lobes and segments, and we know that you have 3 lobes on the right? The right upper lobe, right middle lobe, right lower lobe, and then you have 2 lobes on the left, left upper, left lower, and that's generally due to the position of the mediastinal cavity, right? The major muscle of breathing is the diaphragm, which is inferior to the lungs. In fact, the diaphragm is what separates the thoracic cavity from the abdominal cavity. And we know when the diaphragm contracts, it drops down and decreases the pressure within the thoracic cavity, which causes a volume, or decreases the pressure, which causes the volume to increase. When we inhale, that's an active process, so it tends to happen very quickly. And then when we exhale, the diaphragm and the accessory muscles relax, right? The pressure increases, which causes the volume to decrease, and that relationship is codified in what's known as Boyle's law. All right, you guys good with that? We know that normal breathing is a negative pressure mechanism. When I inhale, I generally have negative pressure in my thoracic cavity. And when I provide positive pressure ventilation, I turn that thing upside down, don't I? And of course, that helps explain some of the negative consequences associated with positive pressure ventilation, i.e. decreased preload to the heart and decreased cardiac output, blood pressure, etc. Okay, cool. You guys good with that so far? All right, so we know that deoxygenated blood comes out of the right ventricle of the heart, travels through the pulmonary arteries into the pulmonary capillary beds where oxygenation occurs, and then oxygenated blood travels through the venules and back into the left side of the heart through the pulmonary veins. This is the only area of the body where you have kind of a contrary mechanism occurring, because generally we say that veins carry deoxygenated blood to the heart and arteries carry oxygenated blood away from the heart, and of course that is the opposite when dealing with pulmonary circulation. So far so good, guys? Okay, protective mechanisms, we talked about these already. Gag reflex, cough reflex. We also know that we have the sneezing as well as hiccups might be considered a protective mechanism. And of course we have those stretch receptors in the lungs, and this leads to what's known as a Herring-Brewer reflex, which prevents overexpansion of the lungs. We just talked about that. Okay. So there are 2 concepts when it comes to moving air in and out of the lungs. And those concepts are known as lung compliance and airway resistance. All right? And this is going to be important when we start talking about different types of pathology. So, lung compliance, the mathematical formula for compliance is change in volume divided by change in pressure. All right? So how much pressure does it take to cause a certain change in lung volume? Okay? So the way that we can look at this is how stiff are the lungs themselves? How stiff are they? How hard is it for the lungs themselves to inflate? Okay? That is one way of looking at lung compliance. So when lungs are poorly compliant, a low compliance, that means that it is very difficult to get the lungs to inflate or to expand. Are you guys okay with that? That is poor compliance. Okay, lungs that are too compliant are open and floppy, and they don't want to go back to their normal size. So lungs that are too compliant, you're looking at exhalation being a problem, right? Getting air out of the lungs, because they're so compliant, they're opened up and they're like, I'm good, I'm open, I don't want to exhale, right? So that's too much compliant. That's highly compliant. Poorly compliant is too stiff. Are you guys okay with that? So low compliance, stiff lungs, high compliance, floppy lungs. That is a qualitative way of looking at it. All right. So things like pulmonary fibrosis and pneumonia and pulmonary edema tend to cause more poorly compliance, tend to cause low compliance, stiff lungs. Other things that can cause low compliance, circumferential chest wall burns, right? If you burn your chest wall, can your chest wall expand? No, it can't, and so that creates poor compliance. Morbid obesity, or just obesity in general, the more obese somebody is, the less compliant their lungs are, right? Particularly when you take someone who's obese and you put them supine, they tend to have a much harder time expanding their lungs. Pregnancy is a disease of poor compliance, and I'll put quotes around disease. The more gravid you become, the larger that baby becomes, the harder it is to expand the lungs. And what do we see? What do moms do in response to that? Their tidal volume goes down and their respiratory rate goes up, right? We see that. We see increased respiratory rate, decreased tidal volume. It's a normal physiological change associated with pregnancy. Other things, abdominal compartment syndrome, where you have lots of fluid and inflammation in the abdominal compartment, that can put pressure up on the lungs and can cause poor compliance. So, does that kind of make sense there? All right, now the other concept is airway resistance. And airway resistance is not the lungs themselves being able to open up and close, but rather it is the flow of air through the passages. Okay, so lung compliance has to do with getting those little alveoli to open and close normally, right? How stiff they are, in essence, how stiff the chest wall is. But airway resistance is airflow through the passages themselves. You guys okay with that? So increased resistance, okay, means that there is obstruction to airflow. Okay? And so diseases of airway resistance tend to be obstructive. So when we say that somebody has obstructive disease like COPD is a number of diseases. It's an umbrella term for several diseases that primarily increase airway resistance, right? Make it harder for air to flow through those passages. Does that kind of make sense? You guys okay with that? So that is obstructive pathology. Restrictive lung diseases, however, a restrictive lung disease is a disease of poor compliance. So low compliance causes restrictive disorders. High airway resistance causes obstructive disorders. And you can also have a combination thereof as well. Are you guys okay with that terminology? Does that make sense? There's a lot of inverse kind of stuff going on in respiratory, isn't there, right? Just like a high CO2 correlates to a low pH, right? And a low CO2 correlates to high pH. You kind of have all of these inverse relationships, and that's also the same with lung compliance. You guys okay with that? Okay, good. Moving right on. All right, so nervous control of breathing, we've talked about this in some detail. But basically you have chemoreceptors, right? These are chemical receptors. That's what chemo means, chemical. And they primarily monitor the pH within the cerebral spinal fluid and within large central vessels, right? So we have what are known as peripheral chemoreceptors and central chemoreceptors. Peripheral chemoreceptors are located in our large vessels like the carotid bodies, and central chemoreceptors are located within the brain. And these chemoreceptors send information back to the brain stem, right? About the pH, and we said that the primary mechanism for breathing is what? Is a pH-based mechanism, right? I.e., that is to say, low pH or high acid levels tend to make us breathe more, right? Low acid or high pH tends to inhibit the drive to breathe. And then if this fails completely, there are some other minor mechanisms, i.e. the hypoxic drive. And we've talked about how people have generally overstated the importance of the hypoxic drive when it comes to like COPD patients. And I believe there's even a section in your book when you read about it There's a few paragraphs that talks about the hypoxic drive, and even it says that it's not as prevalent as we once thought. However, it is still there and might play a role, however small, in the deterioration of certain patients. Okay, we also said that the primary nerve to breathe is the pharynx nerve, right? And you actually have two of them. You have the right and the left pharynx nerve. They innervate primarily the diaphragm, but you also have your accessory muscles, right? You've got your intercostal muscles, and you have your external and internal intercostals, right? The external are toward the outer part of the chest wall, the internal toward the inner part of the chest walls. You have your sternocleidomastoid, right? Your sternocleidomastoid muscles in your neck. And then you also have your abdominal muscles, right? You have your transverse, your rectus abdominal muscles, and they all work to help as agonists to the diaphragm, so we call these accessory muscles. Okay, so our primary breathing centers are located within the brainstem, and you have two centers located within the pons, we call the pontine respiratory group, and then you have two centers located in the medulla oblongata, which is inferior to the pons, right? And the two groups that you have within the pons are the pneumotaxic center and the apneustic centers, right? And in general, the pneumotaxic center tends to be inhibitory, and the apneustic center tends to send a constant signal to inhale, right? So this tells us to inhale. The pneumotaxic center then sends inhibitory information. And so you need to have a balance between positive and negative, right? To inhale, exhale, And this is where we can get really weird breathing patterns with brain injuries, right? If you damage one of those centers, you get these really weird patterns that develop, like Biot's respirations, which we've talked about. You also have the ventral respiratory group, the VRG, which is the ventral. What does ventral also mean? Ventral means what? It's another term for ventral. A&P 101.
So ventral, dorsal.
Yeah.
Is that what you're
Yes.
referring to? Okay.
So what does ventral also mean?
Anterior.
Anterior, right? Anterior. And dorsal, I just think of dorsal fin means posterior, right? So the ventral respiratory group is in the anterior part of the medulla, and the dorsal is the posterior part. And unfortunately, ventral and dorsal tends to predominate when we talk about nervous system anatomy and physiology, which we won't do until med block in any detail. So just commit that to memory. You've got to remember that ventral is anterior, dorsal is posterior. You guys okay with that? Okay, good deal. And the dorsal respiratory group sends stimulatory information to the apneustic center, whereas the ventral respiratory group has both inspiratory and expiratory neurons, and it seems to be a very important regulator during increased physical activity. So at the end of the day, what you have is you have a lot of feedback going back and forth between all of these four different groups, inhibitory and positive or inspiratory and expiratory impulses. And at the end of the day, when it all averages out, you get that, when everything's working normally, you get that eupnea, right? That normal rate and depth of breathing and good pattern. Okie dokie. Along. Okay, so remember gas transport, oxygen. We'll talk about oxygen first. So here's one way of looking at oxygen, right? It's two oxygen atoms double covalently bound. You've got all your little valence electrons, and so this is a very non-polar situation. Oxygen molecule tends to be small, and because it's small and non-polar, it does not dissolve in blood plasma very well, which means what? We have to have an elaborate mechanism for transporting the oxygen, and that is primarily the hemoglobin, right? Hemoglobin is a quaternary protein, has quaternary structure. It is 4 different globulins or what we call 4 chains that come together, and you have 2 alpha chains and 2 beta chains to make 4 globulins. At the center of each of them, you have what's called a porphyrin ring of nitrogen atoms that coordinate with what? They coordinate with an iron atom, right? And the iron is coordinated, and let's see if I can move this a little bit. There we go. So the iron is coordinated. Let's see if we can get rid of that. Okay. So the iron atom coordinates with nitrogen. So you got one here, one here, one here. So the sides. And then you have an amino acid residue connecting to the bottom, which means the only part of the iron that's open is the very top right here. And that's actually where the oxygen molecule comes in and coordinates. Pair of electrons on that oxygen molecule, because electrons are negatively charged. And the iron is actually positively charged in our hemoglobin. And so that positive charge attracts the pair of electrons on the oxygen, and the oxygen molecule comes in and coordinates with the iron. And in fact, the state that iron in is what we call the ferrous state. It is in a +2 state. So it has lost 2 electrons. It has a +2 charge. So ferrous iron can coordinate with oxygen, but occasionally we can get what abnormal forms of hemoglobin. And one abnormal form is what we call ferric hemoglobin, which loses an additional electron. So it's a +3, right? And +3 hemoglobin cannot transport oxygen. And this is also known as methemoglobin. Methemoglobin is where generally some sort of poison or toxin has changed the hemoglobin from its ferrous state into its ferric state, and it is no longer able to coordinate successfully with oxygen. And we call that methemoglobinemia when that occurs. And there are lots of things that can cause methemoglobinemia. There are several. We'll talk about that in a little more detail in toxicology. But yeah, there are several that can cause it. But like I said, that's a whole discussion there. But I won't forget that, because we will revisit that. Cool. All right, we have already talked about CO2 transport, right? And CO2 is CO2 is the last one, so we'll just continue with oxygen. Okay, you guys remember the Bohr and the Haldane effect? The Bohr effect is when that hemoglobin passes through an acidic environment, i.e. tissues producing CO2. CO2 becomes an acid, it's converted to an acid. That induces a right shift in the hemoglobin, and the hemoglobin releases its oxygen. And then as the hemoglobin is going through the lungs, okay, it is more alkalotic, which induces a left shift and allows the onloading of oxygen to the hemoglobin, and that's known as the Haldane effect. So the Haldane effect occurs in the lungs, the Bohr effect occurs at the tissues. And of course, we talked about already the oxyhemoglobin dissociation curve. We said that normally it is a normal sigmoid curve, right? And we plot arterial oxygen saturation as a function of the partial pressure. And generally, as the partial pressure goes up, the saturations go up. And normally, hemoglobin has a very low affinity for oxygen until the first oxygen binds. And then as more and more oxygen binds, the affinity increases until we level off at around 100% saturated. And then, of course, it's fully saturated, and you can't get any more oxygen in the hemoglobin. You guys okay with that? Right? And we talked about what can right shift the hemoglobin. And a right shift is the hemoglobin wanting to release the oxygen, which is a low affinity for oxygen. And I just said the R's, right? Raised acids or low pH, raised temperature, raised 2,3-DPG, and raised carbon monoxide are all things that right shift hemoglobin. We talked about left shift, and think of left shift as a locking. The hemoglobin locks on to the oxygen, doesn't want to let it go, and that is an increased affinity. And I just think of the L's, right? Alkalosis or low acids, low temperatures. low 2,3 DPG or diphosphoglycerate. Right, the little crowbar. Okay, you guys go with that? Okay, how about this terminology here? FiO2 is what? Fraction of inspired oxygen. Okay, what does that mean? It's a percentage of oxygen the patient's inhaling. Right, good. What does SaO2 mean? Of arterial oxygen. What does SpO2 mean? P is for pulse oximetry, right? So this is in the capillaries. What's P big AO2? Big A. P big AO2 there. Alveolar, the partial pressure of alveolar oxygen. What's HBG? Hemoglobin. HCT? Hematocrit. Good. All right, okie dokie. So let's go ahead and talk about carbon dioxide transport now. Okay, so carbon dioxide is also a small nonpolar molecule, right? It looks something like this. Carbon. Okay, so it's linear, it's small. Carbon is bonded to oxygen. So it does not dissolve in plasma as well. So what do we have to do? We have to turn it into something that can dissolve in plasma primarily. And so approximately 60 to 70% of all the CO2 in the body is transported in the form of what? Hydrogen and bicarbonate ions, right? Okay. And just to review, acids do what? They donate protons. And what is a proton? Proton is a hydrogen atom without its electron, or an H+, right? So a hydrogen ion is the same thing as a proton. Bases accept protons, right? Good deal. And there is this concept of what's known as a strong acid and a weak acid. And strong acids, they dissociate completely. So when you introduce a strong acid into water, it gives up all of its protons, 100%. So hydrochloric acid, for example, when you put hydrochloric acid into water, it dissociates completely into hydrogen ions and chloride ions, right? And that is irreversible. It cannot be reversed. You can't really put those back together to make hydrogen chloride very easily. It take a lot of energy. Weak acids, however, okay, weak acids partially dissociate. That is to say, not all of a weak acid will dissociate into its acid form and its what we call its conjugate base, right? And this leads to something known as Le Chatelier's principle. And this gives rise to what's known as an equilibrium reaction. Okay? So if I go back here, okay, you guys remember this formula right here, right? So CO2 is produced at the tissues. CO2 plus H2O gives us H2CO3, which is also known as carbonic acid. And the enzyme carbonic anhydrase catalyzes that reaction. Now, the H2CO3 is generally unstable, and it breaks down into hydrogen ions and bicarbonate ions. And then those hydrogen and bicarbonate ions can be transported in the blood because they're positively charged and negatively charged, right? They're polar, so they dissolve in our blood. And then they get to the lungs where carbonic anhydrase catalyzes their reconversion back into carbonic acid, and then they can dissociate back into CO2 and H2O, and the CO2 gets exhaled through the lungs, right? But we said that this is all, because carbon dioxide, or carbonic acid rather, is a weak acid, it is at equilibrium, which means that these chemical reactions can move this way or this way, right? And so generally what happens is, when I'm producing lots of stuff on this side, the left side, that is going to push the chemical equation which direction? It's going to drive it over here to the right. So, as my tissues are producing CO2, that is going to drive the equation over here to this side, right? So it's going to cause more hydrogen ions to be produced. However, if I were to give somebody a large dose of bicarbonate, right, So I were to give them a bunch of bicarbonate, maybe we give a big dose IV push, what way is that gonna push this equilibrium? It's gonna push it to the left, right? Which is going to increase the production of CO2, right? And that's one of the problems with sodium bicarbonate is it can increase CO2 production by pushing this equilibrium reaction in the opposite direction of what it would normally go. Okay, so if we added more CO2, what would occur? Well, we just talked about that, right? It would make more carbonic acid. If we added a bunch of sodium bicarbonate, that would tend to make more CO2. And remember, we talked about the blood buffer system, and we said that normal ratio of bicarbonate to carbonic acid is 20-1. We should have 20 bicarbonate molecules to 1 carbonic acid, right? And as I start making more and more carbonic acid, this ratio becomes lower, and we ultimately become more acidotic as the blood buffer system becomes incapable of buffering those acids that are produced. Okay, you guys good with that? Okay, how about we stop there and I get you guys on a little break?